Today we decided to bring a example of our very interesting cases in the cath lab. So I brought one of the very interesting, actually, in a unique case. It is a jet-related left atrial lesion. This is a 58 years old woman who was transferred for diagnostic transesophageal echo after 3 months of shortness of breath on exertion, intermittent fever, and recent dental work. She had a positive blood culture of Smith's and multi-site septic emboli, include the splenic infarct, the suspected spinal infection, and also the brain infarcts. She's never a smoker and no history of alcohol and drug abuse. This is the first image you will be greeted with when you are doing the TE. So, any ideas? Any thoughts?
Progress.
It stops at Howard. Yeah. Take. It looks like we're on a sleep area.
More flex on this in the short well. Very large taking in your mass of one leaflets there, kind of prolapsing it in with systole.
Yeah.
Left ventricular size overall looks fairly normal. It looks hyperdynamic.
So here, when we see this view, we would think of a few things. The top of them is prolapse, or would be like probably a vegetation. But just to confirm, whenever we see any mass or any suspicion of prolapse, we have to confirm with the orthogonal views, explain, we have to use color, we have to just confirm with multiple views just to confirm and study the diagnosis. This is the second image when we do the color compare, and you can see also the explain. If you have any comments, any thoughts, no problem. Anyone, so you can give me an idea.
Normal. Okay, what's abnormal about this?
It's not very unfair. The leaflets are very thick.
No. So in the transesophageal echo is the reverse, right? So that will be the anterior mitral leaflets area, and this will be the posterior mitral leaflets closer to the throat. So is that one is abnormal, or both of them are abnormal?
So in this view, we see a short axis with a color compare, and with what looks like a severe mitral regurg. And we can see in the explain abnormal leaflets, which look like prolapsing in the left atrium, but we cannot comment completely yet on this until we complete our views. When we went to the mediasophageal views, we started to have this abnormal large mass that is attached to the mitral leaflet. We see the first image. We see here the four-chamber. We see here the LVOT view. And we see here the zoomed four-chamber on the mitral. We can describe this as moves independently of the leaflet hinge, irregular multilobular surface, left atrial upstream, and of course it's a vegetation taking into consideration the patient history and presentation and the blood culture and the recent dental work, and the multi-site infarcts. So the vegetation morphology and embolic risk. You can see by the first image, the explain, how it looks like, and by 3D as well, we confirmed. Large multilobulated attached to P2 vegetation measuring 29 by 14 with the multiflail segments, shaggy surface with a high independent mobility, protrusion into LA that increase embolic risk. So you see in this 3D, it protrudes very much into the LA. But can you notice anything else in this 3D as well? It's very interesting when we see like a striking diagnosis, we often tend to concentrate only on that. But watch the anterior wall of the left atrium. There is like a very small mass, and there are multiple irregularities, and we will talk about this. This is actually our main topic today. We see severe anterior directed mitral leaflet here by 3D, and it suddenly stops. So anyways, we did the 3D color on the right side, and it's when there is a severe mitral regurg, usually the color is very messy in the image. What we did in the second image, we increased the wall filter to see the jet origin and where it directs into the LA. I will in the show, and I will resume. So it starts again. Yeah, you see this in the image that plays now on the left side. You see that it hits the wall, the anterior wall. So it's an anterior directed jet. And by this view, with the normal wall filter, we don't see how clear it is. So it's a severe anterior directed jet from flail P2. Jet is directed anterior to the LA or aortomitral curtain. The focused jet momentum that causes endothelial shear and thrombogenic surface. Here we zoomed on the mass we saw, but by 2D, which shows us the origin and shows us if it is single or multiple. So it's a multiple heterogeneous mobile mass that clusters in the anterior left atrium. Orthogonal explain confirm the atrial wall attachment, and you can see here in the image on the right, you can see a live 3D and how mobile it is, independent of the wall that's attached to it, and you can appreciate also multiple small scattered thrombi next to it. So, what do you think management will be in this patient who has large, mobile, multi-scattered thrombi and vegetations and embolic phenomena? Positive blood culture, of course, it will be surgery, but after multidisciplinary meeting and discussion with the patient about the decision. So the patient went for surgery, and this is the same view that we saw a while ago, and there is no more masses. It's been cleaned out, and the mitral valve has been replaced. Actually, this case has been reviewed in the literature. It's only about 5 or 6 case reports that has been reported as left atrial mural mass, or they mentioned it as a jet lesion, effective endocarditis. These are the case reports that has been reported since 2005 until 2024. So we will go with the pearls about the presentation. In patients with bacteremia, embolic phenomena, early diagnostic TE is essential to localize valvular or mural disease. First impression are valuable, but must test both multiple orthogonal views and clinical data correlation. Optimizing the orthogonal explained 3D views are essential to distinguish leaflet prolapse from attached mass. When there is vegetation, full scan is mandatory to rule out disseminations. Vegetation mobility, surface irregularity predict embolic potentials more than size alone. Severe eccentric regurgitation jet is both hemodynamically significant and mechanical cause of focal atrial injury. Multi-site embolic disease strengthens the indication for early surgical intervention. Thank you very much. I really appreciate your listening. Any questions?
So one of the mechanisms, because the jets keep hitting the endothelium and actually keep eroding it, so you create like a raw sore. So then now becomes a place where the bacteria can actually implant. So we actually, like, first of all, the message is very important to look around, just like rather than just focusing on the what is obvious, to look around and make sure there's other masses in the heart, because like sometimes that could be easily missed. I mean, if you look at it originally. So the fact that you and your staff colleague actually went along and interrogate all of that is actually very important. So kudos. So you don't miss that. And then the second piece is to put everything into context and move from there.
Yeah. There was a question about the choice of the prosthesis.
Oh, let's go to the chat. So
why bio versus?
It was the patient choice because the prosthesis in the future, she was at this age. In the future, if she needs, she will end up with open heart surgery again, and she will need to be on anticoagulation lifelong and frequent follow-up for INR. And she preferred to have the bioprosthesis for possible future. If there is any intervention, she would go for intervention, and no need for regular follow-up for INR and investigations.
So can you discuss again further the indication for surgery for endocarditis?
Yeah, the indication for surgery is as this patient, multiple embolic phenomena. The patient did not have good response to antibiotics, large mobile mass that is tending to disseminate, and heart failure that is caused by severe valvular dysfunction.
Okay, so that's actually a good indication.
Yeah,
recalcitrant heart failure, despite optimal medical management. The other one that I remember, correct me, these days is recurrent embolic phenomenon despite being on adequate antibiotics treatment. So those are the ones that we would go after. Sometimes as size actually would be another indication for that, and so on and so forth.